Hello and welcome back to our graphic medicine modules. I'm Dr. Rachel Thomas. This is Module 2, and today we're going to focus on historically othered bodies in medicine and society, and how artists and comic artists have started important conversations in medicine in order to reduce stigma and improve health outcomes in patients. I'd like to acknowledge that funding for this set of modules comes from the Heal Healthcare Project via the National Collaborating Center for Indigenous Health. The Hearts-Based Education and Anti-Colonial Learning Project, or HEAL, is funded in part by Indigenous Services Canada. As much of this research and creation was conducted on Quebecois soil, I would like to take the time to recognize that I acknowledge that my work in Tiohtià:ke, or Montreal, takes place on the unceded Indigenous lands of the Kanien'kehá:ka, or Mohawk Nation. In medicine, we know that as much as possible, we try to be objective, but unfortunately, sometimes biases still creep in. Today, I'm going to be talking about 3 specific types of othered bodies in medicine, their history with the discipline, the biases that have been born of this history, how we as Canadian healthcare professionals can begin to address these biases, and examples of graphic medicine that are already starting to do so. The representation of bodies in comics is a complex and evolving aspect of the medium, reflecting cultural, social, and artistic influences. We have the obvious representations, the superheroes, the femme fatales, and even the anti-heroes. But today I won't be focusing on those types of bodies. Instead, I'd like to have a look at bodies that are not normal or othered, meaning that which is not like ourselves and oftentimes away from the norm, which in Western culture is still predominantly white, cisgendered, and heterosexual. Where does the word normal even come from? Quite literally, it comes from the Latin norma, meaning carpenter square, straight. And abnormal? That's from the Greek anomalos, and the Latin abnormis, meaning monstrosity. Monstrous is an interesting concept because from the Latin monstrare means to demonstrate, which tracks with what monsters were originally supposed to do, to serve as a warning in fairy tales and children's stories. Drawing from phenomenology, we consider that to be a body is to be tied to the world. We understand the body to be a physical entity defined by and against social norms, which moves in accordance with or in opposition to these norms. A body can therefore be normative, a normate. Bodies that do not physically or socially conform to social norms have been defined negatively as abnormal, that is, in opposition to normal. Theorist Michel Foucault also talks about how the medicalization of the body is a means of disciplinary control. He refers to a concept that he calls the medical gaze, which is the objective viewpoint used to break down bodies into parts and symptoms to be analyzed, and in doing so, erasing the patient as an actual person. It also creates binaries, well and ill, normal and abnormal, as categories. The main goal of medicine is to return bodies to their full function. In a Marxist view, this would relate to the work a body produces, but we know that it's actually more than this. Any bodies that fall short are categorized as abnormal because they don't adhere to the medical and social norms. These are the bodies that are considered othered in medicine as well as society. And through medicine as an institution, we seek to correct these bodies. Another important scholar who studied this binary was Georges Canguilhem, who Foucault references quite a bit. To understand what is normal, he says, is to be able to understand its opposing pathology. This, of course, can be a point of contention, because wouldn't pathology of a body have many gray areas, not just a simple binary? He goes on to state that normative in the fullest sense of the word is that which establishes norms. Thus, the concept of homeostasis, that is the active maintenance of a medically well-balanced body, would be considered the norm. Medicine, therefore, sees other bodies as groupings of corporeal problems and works to cure, fix, or eliminate those problems, whether it be disabled bodies, racialized bodies, fat bodies, or queer bodies. The most important takeaway here is that in order for homeostasis to occur, the othered body must be forced to change. Further, our culture perpetuates the idea that in order for other bodies to be successful, they have to deny themselves and become as normal as possible. As an example, the concept that persons with disabilities are, quote, just like everyone else. This is problematic because it forces the idea that the social worth of an individual is tied up only with their adhesion to the norm. Even the category of disabled is heterogeneous. There are still multiple facets missing from the identity matrix, such as gender identification, race, class, life experiences, and the list goes on. So other bodies do exist, and both medical and social gazes seek to normalize them, when sometimes this is actually detrimental. I'll begin with speaking about racialized bodies, particularly the Indigenous peoples of Canada. Rosemary Garland Thompson, a renowned disability scholar, speaks about different types of othered bodies and how they have existed and do still exist in medicine and culture. I'll start with the outcast. The birth of the asylum is the birth of institutional efforts to correct those deemed undesirable, incorrect, or immoral in order to normate society. But the MAD were not the only bodies to be removed from society and imprisoned for the social good. The goal, as Michel Foucault argues in Docile Bodies, was to exert state power over the body, to make the body an extension of the state in action, appearance, and morality. Canadian residential schools, which impacted an estimated 150,000 Indigenous children, are a huge example of state imprisonment. These included things like forced assimilation, where children were separated from their families and subjected to harsh conditions. Medical experimentation without informed consent, inadequate healthcare access, and cultural insensitivity in mainstream healthcare systems have also contributed to mistreatment. These issues, even in the 21st century, have led to mistrust and disparities in health outcomes, highlighting the need for culturally competent and respectful healthcare for Indigenous communities. The first Catholic Church-run residential school opened in 1831, with the federal government stepping in officially to fund the institutions in 1880. The express purpose of these schools was to separate children from families as a means of forced assimilation. Children were taken from all over Canada, including Métis, First Nations, and Inuit. In addition to the poor education, environment, and abuse, medical experimentation also occurred, oftentimes unethically. There were cases of residential schools where children were subjected to nutritional experiments, often without informed consent. In the 1940s, the government noted that the high numbers of malnutrition in Indigenous students at such schools, but instead of changing policies to provide better food access, researchers were sent instead to study the effects, citing the need to have hungry people to prove their theories. Control groups were created, depriving the children of essential nutrients. Some students received adequate nutrition, where others were fed an experimental fortified flour mixture, sometimes mixed with substances like bone meal, which created anemia in addition to malnutrition in the test subjects. As if to add to the biases against Indigenous peoples, there was a theory that the so-called Indian problem was due to malnutrition, not necessarily racial traits. There was a common belief in medicine and society at the time that Indigenous bodies were racially inferior because of their nutrition. What wasn't seen was that the colonialism in the form of the Indian Act was the main issue. Lands were stripped bare and taken from tribes, children were sent to residential schools, limits were placed on traditional practices of hunting and trapping, and many more issues were what contributed to malnutrition among Indigenous people. This information, taken from residential schools, was used as a basis for Canada's food guide, which we now know isn't necessarily health promoting. Another example is the Indian diabetes study, which took place from 1963 to 1973. Researchers studied diabetes among Indigenous populations without proper informed consent. In fact, participants were often unaware of the nature and potential risks of the research. The forced sterilization of Indigenous Canadians is a dark chapter in Canada's history as well. From the 1930s to the 1970s, Indigenous women, particularly those in residential schools, were subjected to coerced or forced sterilization processes. The practices were often based on discriminatory and eugenic ideologies aimed at limiting the population growth of Indigenous communities. These sterilizations occurred without informed consent, and the affected individuals did not fully understand the nature and consequences of the procedures. The traumatic legacy of forced sterilizations has had profound and lasting impact on Indigenous communities, contributing to a legacy of mistrust towards healthcare systems and authorities. The mistreatment of Indigenous people by Western medicine in Canada is rooted in a complex history of colonization, cultural misunderstandings, and discriminatory ideologies. The imposition of Western medical practices on Indigenous communities often involved a lack of respect for their traditional healing methods. Contemporarily, biases still exist against racialized bodies such as Indigenous and people of color. A study was conducted in 2002 by the Institute of Medicine in the States that gave us evidence of some disturbing disparities in healthcare among minority communities. They were looking for whether or not there was concrete evidence of difference between minority communities and the white community that was not based on things like access to care, ability to pay, or insurance coverage. Instead, they were interested in the role of biases and discrimination in healthcare at all levels. It was found that there are disparities in healthcare even when external factors and the medical condition of the patients are comparable. While being uninsured can harm overall access to healthcare, these findings show that even at the same level of insurance, minority groups were receiving lower quality care. This bias is at a level that is across the healthcare system, from top to bottom. Black and Hispanic individuals received lower quality health care than white individuals, and this was over a broad range of diseases: cancer, cardiovascular disease, HIV and AIDS, diabetes, and mental illness. Black individuals were also more likely to receive certain less desirable treatments, such as amputation of all or part of a limb. Historically, Black bodies were thought to have thicker skin and less nerve endings than white bodies, and were therefore more immune to pain. We know now that this is not the case, but it's taken a variety of different studies and teaching methods to actually disprove that myth. And unfortunately, some medical students still hold this bias. Further, many studies were done on white men in particular, and certain conditions weren't acknowledged in Black bodies or people of color. Resident dermatology student Malone Magwende, who is from London, wrote a book on this exact issue, describing how certain skin conditions present in Black and brown patients. Before, it was thought that these skin conditions presented the same as they do in white bodies. Racism is still a factor in healthcare, and there are three specific types of racism that can occur. The first is institutionalized racism, where the system discriminates against patients based on their race. In fact, it's codified within the power structures. There's personally mediated racism. This is where stereotyping would come in, as it relates to a personal prejudice against an individual. In an IOM study, doctors reported Black patients as being less intelligent, more likely to abuse drugs and alcohol, more likely to fail to comply with medical advice, more likely to lack social support, and less likely to participate in cardiac rehabilitation than white patients. There's also internalized racism. This is the type of racism that occurs when stigmatized individuals accept the messages they're receiving as truth, which leads to questioning their own self-worth and abilities, and the self-worth and abilities of others in their community. So what is being done to address racism in Canadian healthcare? Stopping medical discrimination against BIPOC Canadians requires comprehensive efforts at various levels. Implementing mandatory cultural competency training for healthcare professionals is a great start, as it increases an understanding of BIPOC cultures, histories, and healthcare needs. It's important to involve communities in decision-making processes to ensure that healthcare policies and programs are culturally appropriate and meet the specific needs of these communities. Raising awareness about biases and stereotypes promotes a more inclusive and respectful healthcare environment. This includes challenging and correcting misconceptions about BIPOC communities. It's important to ensure that patients are fully informed about their healthcare options, their procedures, and their rights, emphasizing the importance of obtaining genuine informed consent. We can also start to develop healthcare services in our practices that are culturally sensitive and responsive to the diverse needs of BIPOC communities. For instance, incorporating traditional healing practices where appropriate. As healthcare professionals, We can also advocate for policy changes at institutional and governmental levels to address systemic issues, reduce healthcare disparities, and allocate resources to improve healthcare access. Increasing the number of BIPOC healthcare professionals and community health workers enhances cultural understanding and improves communication between healthcare providers and BIPOC patients. And finally, using trauma-informed care. Trauma-informed care approaches, recognizes, and addresses the historical traumas experienced by Indigenous and BIPOC individuals, which can foster a more compassionate and understanding healthcare environment. Graphic medicine is serving as a means to address some of these points and more effectively reach communities due to accessibility. Through arts-based research, we have Dr. Omar Mirza, a psychiatrist, who created a comic based on research he conducted that looked at how BIPOC were excluded from VIP floors at an academic medical hospital. It fully includes all of the traditional elements of a research study, but in a way that's both informative and accessible to all types of communities. It Takes a Village by Zoe Hopkins, a Monclay Nahulapan, and published by the Healthy Aboriginal Network, is a short comic about a young Aboriginal girl getting in touch with her ancestors' wisdom about raising and conceiving a child, and her progeny's spirit as a mother later in life is her guide throughout the tale. It's geared towards Aboriginal teens and young mothers and talks about respecting your child through your pregnancy and listening to the wisdom of your parents and grandparents. It also speaks of the difficulties in pregnancy itself, in addition to single motherhood, providing validation and information for its Indigenous readers. Some Indigenous medicine practices are now being incorporated into Western medicine through art. This is a good example of an expanded medicine wheel that discusses health during COVID-19 from researchers at Women's College Hospital in Toronto. Since its emergence as a creative genre and a scholarly field, graphic medicine has consecrated a canon that centers predominantly white, middle-class narratives, and the field in general has been dominated by these narratives. COVID-19 has opened the field up to a diversity of views and narratives, especially given that the loss of life and livelihood has disproportionately affected Black, Indigenous, and BIPOC communities. To address this, works like this one from Navajo and Hopi families' COVID-19 Relief Fund, written in both Diné Bizaad and English, go through the symptoms and precautions with COVID-19. Researchers recognize that due to health inequalities over generations, lack of adequate food and water sources, and other health conditions among the Navajo reservations, COVID-19 would become a significant health concern. This poster was one of many ways to address the growing risk. The community needed something that would connect with them on a cultural level, which also involved collaboration with Indigenous artists as a trusted source. Another great example of ethnographic graphic medicine is Lissa, a story about medical promise, friendship, and revolution. As young girls in Cairo, Anna and Layla strike up an unlikely friendship that crosses class, cultural, and religious divides. Years later, Anna learns that she may carry the hereditary cancer gene responsible for her mother's death. Meanwhile, Layla's family is faced with a difficult decision about kidney transplantation. Their friendship is put to the test when these medical crises reveal stark differences in their perspective, until revolutionary unrest in Egypt changes their lives forever. The first book in a new series, Lissa brings anthropological research to life in comic form, combining scholarly insights and accessible, visually rich storytelling to foster greater understanding of global politics, health inequalities, and solidarity. Another type of othered body Garland Thompson speaks about is supernatural. She uses the term freak to encompass othered bodies before and through the 19th century commodification of the freak as spectacle in exhibition halls. The freak, whose body is subject to inferences of cultural anxieties, has always existed. As Garland Thompson argues, it was once a sight of wonder, an example of physical evidence of divinity. It was believed that the divine touched those who were extraordinary. They were children of gods or of monsters, inspiring awe and aversion. The wondrous embodiment of the freak endured until roughly the 19th century, when industrialization and social apparatuses of regulation began to privilege and prioritize the normate above all others. Remember the concept of the medical gaze? Well, Garland Thompson argues that while the gaze is a means of dominance over the body, disabled bodies are more often subjected to a more aggressive stare. The stare, established through medicine, seeks to establish the disabled body as other in order to confirm the non-disabled person's normality. It is similar, of course, to Canguilhem's theory that the normal is only established through what is pathological, or what Foucault references as deviant. This establishes disabled bodies in a social and medical concept as spectacle. I'll begin with the history of disability in medicine. There is a long history, but I wanted to do it in manageable chunks because there are some interesting kernels of information from the past that are still relevant to the disability discourse of the 21st century. We are going to start our journey in the 11th century, or what we would call the medieval period. Interestingly enough, those who were considered to be disabled were treated as part of the community. They were highly visible and regular parts of the community and were recognized because of either a disability from birth, one from a later accident, or one caused by disease, such as leprosy, which was rampant. While disabled individuals were not forced into confinement at this time, attitudes were a bit mixed due to religious teachings for the most part. It was thought that disabled individuals were actually a physical embodiment of a family's, usually mother's, sins, and were born as a kind of punishment to the family. Other beliefs held disabled individuals in high regard, as it was often thought that in suffering in a disabled body, they were going through purgatory, and that when they died, they would be with God immediately. If work couldn't be had, sometimes disabled persons would have to resort to begging. However, the Church during this time taught monks and nuns to care for such individuals as part of their Christian duty. Many would have been taken in and cared for, all the way up until burial. During the 11th century is when the earliest instances of hospitals and pseudo-asylums began to emerge, which were either directly connected to the church or were close by. These places would house many disabled individuals, in addition to those who were struggling with debilitating diseases, like separate colonies for lepers. One such place you may recognize is the Bethlehem Hospital in London, which would later have the name Bedlam and be an institution for mental and physical disorders. I'll skip ahead a bit to the 16th century, as things stayed fairly status quo with regard to disability throughout previous centuries. We had something big happen during this time. The king, Henry VIII, had split from the Roman Church and had demanded for the dissolution of monasteries. This meant that the hospitals and workhouses and care provided for disabled individuals by monks and nuns were destroyed, and without anywhere to go, they were left to fend for themselves on the streets in poverty. A petition in the mid-1500s to the king begged him to re-establish some institutions for the mass amounts of individuals in this predicament, but little was done. Instead, it was the community that took over. Rich benefactors began to build institutions to house disabled individuals, but it was widely seen as a publicity stunt and not as a means to help their fellow man. Churches began to rebuild structures as well, and by the 1600s, hospitals and sanitariums were popping up again. An interesting law was also implemented during this time. As there were many individuals living in poverty at the time, there was a law passed that punishment could be executed on the poor considered to be living idly, rather than having an ailment that prevented them from working. Relief from this punishment was given to disabled individuals. Like the 11th century, we have somewhat conflicting ideas around disability during this time. On the one hand, some disabled bodies were beheld as fools, but were thought to be a particular source of wisdom and humor. However, there were still some serious religious undertones with regard to being born of sin, which was really exacerbated by the barber surgeon Ambroise Paré. Ambroise Paré is considered to be the father of amputation surgery. He wrote a number of treatises on this, but one of his more well-known ones actually has to do with disability and deformity, entitled Monsters and Prodigies. Paré noted that there was not a book that categorized disability, so decided to put one together himself. He was trying to be as scientific as he possibly could with the information that he had, and in doing so could help those trying to diagnose infants with a possible deformity or disability. Monsters, in his definition, were seen as anything that was beyond the norm. He mentions conjoined twins, children with horns, unusual tumors, and mental deficiencies. Prodigies were seen as somewhat closer to what we know today as monsters, like for instance a child being born with the bottom half of a snake, or a snake woman. This book was seen as a problem at the time, as it was feared that the general public would get a hold of it and try to treat problems instead of seeing a physician. As such, the book would begin to act as a sort of grimoire instead of a medical handbook. It would also serve to remind women not to do certain things during pregnancy, so as to not create a monstrous body or birth a prodigy. Paré states things like a mother's imagination or state of mind may be a reason for a child to be born a monster. In the 18th century, things began to change as there were advancements in medicine. It was no longer connected to anything religious, as in anything occurring because of some divine intervention and punishment, and was rather understood to be a loss of reason, which was secluded in the mind and could be treated. As this was not the disabled individual's fault, they were given charity and care, but still funded by the church, not the state. Even during this time, disabled individuals were often faced with poverty, but this was basically most lives at the time. While there were institutions available, not many disabled individuals lived there. Generally speaking, they were still part of their communities and given jobs if they could do them, and were allowed to marry if they wished. However, at the end of the 18th century, the common belief began to arise that all disabled individuals should be institutionalized. The beginning of the 19th century is when asylums really had a boom. Unfortunately, life inside an asylum was grim, so as not to invite someone who was living idly. Anyone considered of sound body and mind would avoid these institutions, but those with physical and mental disabilities were housed there permanently. These places often held doctors, known as alienists, which was a sort of precursor to a psychologist, who wanted to use the asylum as a place to cure and rehabilitate disabled individuals. However, as we know today, there are certain disabilities, both physical and mental, that do not need nor have a cure, so many people living there lived there till their deaths. We now arrive at the 20th century. There are still asylums, and Bedlam still exists to house those who were deemed disabled or morally unsound. The beginning of the 20th century was difficult as well. Hereabouts is where prominent public figures start to discuss the idea of eugenics a little bit more seriously. They begin to see disabled individuals as a serious burden to society, and not just disabled individuals, but really anyone deemed insufficient in some capacity or another. These individuals thought about who is deficient and in what way, and whether or not the practice of eugenics should take place so as to create a better population of more perfect bodies. The idea was that disabled bodies required extra care and maintenance than normal bodies, and were unable to give anything in return to greater society. So from a Marxist perspective, were useless as human beings. The practices of trying to perfect the human race happened before Hitler and the concept of the Aryan race. As a side note, during Hitler's extermination of Jewish populations, queer individuals, Roma peoples, and disabled individuals were also categorically eliminated so as to cleanse the population of so-called deviancy. The Zoological Society and a Eugenics Society in London in the 1930s noted that the undesirables were locked away, but wanted a way to make sure that no more deviant bodies were born. And so, sterilization became a regular practice in sanitariums. A big change to the landscape were soldiers returning from war with mental and physical limitations. Thoughts towards the treatment of disabled individuals began to change slightly because of this. There were new advances in prosthetics for deformities, new services to treat mental and physical trauma, and there was a push for employers to hire disabled persons. There were even special workhouses created to offer employment to those who were previously denied the chance to work. However, eugenic practices were still in play. Even if a disabled individual was out of the sanitarium and in one of the smaller rural colonies, there were still strict rules about age, ability, and engaging with others sexually. We are now closing in at the end of the 20th century, almost moving into where we are contemporarily. We spoke a little bit about the Second World War in terms of eugenic practices, but I'll skip ahead a little bit. In the 1960s, the civil rights movement is beginning to gain speed in the States. Disabled activism groups are rallying and taking action against discrimination and inequality against disabled individuals. During this time, there was a switch from a medical to a social model of disability, which would inevitably change the treatment of disability as well as the discourse. In 1995, the Disability Discrimination Act was passed. The Act noted such things as disabled individuals having equal access. So, for instance, for ramps to be installed where a person could not use stairs, or parking placards. This was something that all architects began to include, and it has been improving on a global scale. 1981 is thought to be the end of the asylum days. Disabled individuals were encouraged to return to a greater community as they had lived in previous centuries, and were helped by care in a community that provided access to health care and general help in daily life. However, even after the Americans with Disabilities Act was passed in the 1990s, discrimination is still rampant. In 2022, a Northwestern Medicine, with collaboration from UMass and Harvard Medicine, study of national practices reports that physicians may be choosing to deny care to people with disabilities, and some use discretionary excuses to strategically discharge them from their practice. The study consisted of analyzing data from focus groups with physicians drawn from a national database. Physicians who participated in these groups expressed biases towards people with disabilities, and a substantial number of participants reported that they make strategic choices to deny care to people with disabilities. This includes making statements such as, "I am not taking on new patients," "I do not take your insurance," or telling the patients that they need specialized care and therefore, "I am not the doctor for you." Additionally, physicians in the study described a lack of knowledge about how to provide accommodations for people with disabilities, and some expressed adversarial attitudes towards the ADA, suggesting that the legislation works against physicians. Prior studies have reported that people with disabilities have difficulty obtaining appointments with physicians and are known to receive less preventative care than their non-disabled counterparts. Another study in 2021, led by Dr. Lisa Lazzoni, found that over 82% of physicians in the States view people with significant disabilities as having low quality of life. Her team's 2022 follow-up study revealed that physicians' preference not to treat persons with disability, admission to uncaring treatment, or incorrectly telling patients that their practices were closed and not accepting new patients. Similar to reducing stigma and discrimination against BIPOC bodies, there are a few things that healthcare professionals can implement into their practices right away to remedy the problematizing of disabled bodies. First of all, talking about disability. Not talking about it is sometimes worse than talking about it. Creating space for a patient to share their experiences of living with disability can be helpful. Further, there are words that were used in the past to talk about disability in medicine, like the word retarded, which is no longer appropriate and considered ableist and offensive. It's important to know how to speak with patients about their disability without coming across as biased or ableist. We can also begin to redefine disability. To create fundamental change, healthcare professionals should rethink the word. Rather than use this term to describe deficiency of an individual's, clinicians and others can adopt the social model of disability. This model states that disability results not from any physical or mental condition, but from environments and programs that do not accommodate or are not accessible to a person's unique functional level. Alternatively, think of disability in the medical model as a negative or intrinsic condition that disadvantages a person and must be cured or fixed. The idea is to put disability into the context of the environment that the person engages. In the social model, a person's physical disability doesn't prevent them from going on a walk in their community. It's the absence of sidewalks, curbed cutouts, or a lack of a wheelchair or other mobility supports that prevents the ability to engage in the community. Making the workplace more accessible is important. There have been cases wherein even doctors' offices and clinics are not wheelchair accessible. This can be addressed as part of changing infrastructure, but it's something that able-bodied individuals don't think about. Not only that, but folks with autism spectrum disorder can sometimes be overwhelmed by sensory experiences. Recognizing that even TVs and overpowering sounds from a radio in a waiting room might not be the best choice. Setting up a disability network could also be helpful. This could be a local network you set up that will help disabled individuals to share their experiences, find resources outside the clinical setting, and even chat with other healthcare professionals on better care practices. Graphic medicine researchers are also tackling disability in quite interesting ways. This book that just came out, The View from Down Here, Life as a Disabled Woman, is by Lucy Webster. It's an intersectional work in that it's looking at how women's lives are shaped by sexism and expectations, and how disabled people's lives are shaped by ableism and complete lack of expectations. This powerful, honest, hilarious, and furious memoir from a journalist looks at life at the intersection, the struggles, the joys, and the unseen realities of being a disabled woman. From navigating the world of education and work, dating and friendship, to managing care, contemplating motherhood, and learning to accept your body against a pervasive narrative that is somehow broken and in need of fixing. The View from Down Here shines a light on what it really means to move through the world as a disabled woman. Sensory, Life on the Spectrum, is an anthology of comics that tackles not only stories coming from folks with ASD, but also how to form communities, information on the aspects of the disorder, and navigating a medical diagnosis. It also provides validation on the experience as much as information for the reader. We also have A Quick and Easy Guide to Sex and Disability by A. Andrews. Sex is a difficult topic to speak about. It's still taboo, and even more so when it comes to sexuality and disability. Andrews' comic is informative and funny, breaks down barriers, and offers comfort as much as a how-to guide in safe practices for disabled bodies. This is here to help you, Helen Cara and Julian Gray. Cara has fibromyalgia and was working with the Deaf and Disabled Persons Association to create a comic that examined disability organizations themselves. She found that these organizations struggled to articulate their value to funders and partner agencies. She immediately thought a short comic could help. She had already analyzed some data demonstrating their value and had initial findings she thought she could use. Cara wanted this research to be accessible and memorable, which, from the feedback she received, was achieved through the form of comics. The last othered body has to do with perceived health. As Foucault demonstrates, the development of biomedicine led to the classification of bodies as either healthy, proper, normative bodies, or unhealthy, improper, flawed bodies that needed to be cured in order to contribute to society. Much as queer and gender non-conforming identities were diagnosed as deviant disorders by medical professionals, physical otherness was, and continues to be, diagnosed as a health issue and treated in an effort to convert it to normality. Obese people, for instance, or people who have been disfigured, injured, or contracted an illness, or who have aged, are othered. So how did we get to the idea that fatness was synonymous with ill health? And furthermore, how did we get to the idea that fat was something that was deviant? We can blame a changing economy and industrialization. 100 years or so ago, plumpness in women was considered to be excellent because it indicated that a woman was healthy, well-fed, and of a higher social class. She would therefore be fertile, and even in the most basic sense, be able to stay warm. Only in the 1800s, when food became more abundant to more and more people, fatness was no longer associated with being rich. In fact, the prominent discourse around body size established those who were sickly thin as superior, such as poets and artists like Edgar Allan Poe and Emily Bronte, though they both had tuberculosis. Thinness at the time was therefore associated with intelligence and moral superiority. This mindset has unfortunately carried over into contemporary culture. Multiple studies in recent years have determined a bias against individuals who are categorized through BMI as obese. They are often stereotyped as lazy, stupid, and worthless, which is particularly pervasive from healthcare professionals. And so there is a melting pot of both medical and social discrimination that happens. If we think about it in these terms, medicine as an institution has already decided that fat is bad, therefore fat must be fixed. A doctor tells a patient to lose weight by going on a diet and exercising a certain way, and to come back in for a checkup. This is a means of surveying the adherence to changing the problem, which is really an entire human being. There is an expectation to fulfill here, and the surveillance is not only coming from other people, it's coming from the self. Through the social contracts and media exposure we receive every day, the expectation is that if you are an othered body, you have to become more normal. These expectations lead to a particular kind of self-surveillance, like constantly logging information into a Fitbit app, for instance. I'm not saying that this is inherently something that's wrong. In fact, we need to look at it in terms of a relationship between the institution of medicine and the person, with no malice consciously intended. Where it may become problematic is when an individual feels that they have no choice in the matter, either not losing weight or losing weight. And if we consider social capital, the impetus on adhering to whatever is most common at the time is extremely high. It's exciting that things are beginning to change in the sense that there is some realization that all bodies are actually different and require different things to thrive. The idea, for instance, that using BMI as an accurate account of predicting future diseases, which I'll discuss in a moment, is no longer valid, and that many other indicators not necessarily related to size may actually relate to overall health. However, this is just the beginning. There is still a significant social disgust with bodies that are not normal, and this is something we should try to actively change. As I mentioned when I was talking about my own graphic medicine practice, we're supposedly facing what our society has called an obesity epidemic. Let's have a look at the word obesity and its inherent meaning. Heavier than average, and average by only the mathematical sense, is referred to as overweight or obese, with the latter being used as a weapon to medicalize diversity. Now that being said, it goes on the same spectrum as calling an underweight individual anorexic. Anorexia is a severe mental illness, but both people with anorexia and people with obesity are considered abnormal and are expected to return to a more normal state. This scale is perpetuated through a number of sources, not the least of which is the federal government, medicine, and big pharma. But there is trickle down from these larger institutions to the individual. As a society that surveys others as much as ourselves, anyone can be an expert in who is obese and who should change based on the most current societal norm. Medicine, influenced by the governing body, established quantitative and positivistic ways of categorizing people into groups based on their mass. And it is no doubt everyone has come into contact with a BMI scale. The BMI, or Body Mass Index scale, measures height and weight to determine a number which is considered relative to the health of the individual. Underweight is anywhere under 18.5. Normal is 18.5 to 25. Overweight is 25 to 29, and obese is 30 plus. Once a person reaches the 40s, they are considered morbidly obese, meaning that their weight is more likely a factor in their risk of dying. Let's look at this a little bit more closely. Higher than normal BMI has been connected to things like hypertension, diabetes, and multiple cardiovascular disorders. However, when a correlational statistic is taken to determine the variation in outcomes due to that variable, it is demonstrated that only 9% of an outcome is somehow related to BMI. This leaves a whopping 91% that is not determined by BMI. What is not covered here, again, are any of the social determinants of health. How are individuals eating? Are they exercising? What is their social status? How does stigma affect body size? Meaning that the correlation between obesity and morbidity is not cut and dry. Further, from a physiological perspective, BMI does not take into consideration muscle mass versus fat percentage. Many athletes, particularly weightlifters, will be classified as obese despite having very little body fat and exercising continuously. However, like we discussed before, there is an inherent binary that is developed. Through both medical and social gazes, bodies are reduced to numbers, and the word obese has become a threat. Normal ranges of bodies are sought after, and those who are already in that category live in constant fear of getting fat. Being fat is synonymous with being indulgent and a moral problem to be avoided. Succumbing to fatness is synonymous with personal failure and a failure of individual responsibility, as much as it is a failure of self-discipline and surveillance. It's also important to talk about the diet industry. We live in a culture of cures for all sorts of things, and since body size has become medicalized, of course this will be included. Weight loss treatments in the form of pills and diets and surgeries have been implemented, but what are the statistics on this? In 2000, the Behavior Risk Factor Surveillance System survey conducted that 46.3% of women and 32.8% of men were actively trying to lose weight. This number was expected to grow. Success rates for long-term weight loss, however, were not good, and most would return to their original weight between 4 to 5 years after. How is it that we are so enraptured by diet culture if it does not work? In a word, testimonials from other people as representatives stand in for empirical evidence on weight loss interventions, because actual commercial weight loss companies will rarely provide their success rates. So how can we begin to address fat biases in our own practice? Well, beginning with spending a little bit of extra time with our patients to determine whether there is in fact a correlation between body size and ill health is a good place to start. In the brief 10 minutes that's allotted, it's important to get a detailed history. In a similar vein, looking at how social determinants of health can actually lead to problems later in life, regardless of size, is also an important aspect. But perhaps most importantly, advocating for patients to take accountability for their own body and choices surrounding that body will make better health outcomes. We are constantly influenced by the media, and there is no way around that. If a patient chooses not to lose weight, they're not normal. If they choose to lose weight, they might be seen as giving in to the institution. Regardless, it comes down to personal choice and personal responsibility. As feminist theorist Roxane Gay says, mind your own body. Since I've already spoken about Shrink, Story of a Fat Girl, I'll also address another graphic novel that talks about fatness, but why this one actually contributes to problematic rhetoric around fat bodies. This is a short autobiographical graphic novel by Carol Leigh entitled The Big Skinny: How I Lost My Fatitude. It follows the story of a woman who is desperately wanting to lose weight through pills, diets, and quack medicine, but who is finally able to find balance and change her attitude as well as her life. From a fat scholarship and graphic medicine perspective, this book is problematic. First, it reads more as a how-to guide, including recipes, calorie breakdowns, and exercises, rather than discussing the concept of fatness in a greater context. Carol, as a character, is the quintessential bio-citizen. She does exactly what her doctor tells her to do, counts calories, exercises a certain way, and she loses weight. She follows the strict rules of society and medicine and is rewarded with a sense of moral superiority. The problem with this is that following this regime is rarely sufficient for anyone. In addition to weight problems not necessarily being tied to food consumption, strict diets rarely last because they are so limited. Leigh also uses incredibly problematic phrasing in the novel, such as fat versus normal, indulging but carefully noting the exact amount of calories in a food she's eating, and not addressing her own biases towards other fat people. For instance, she is visibly horrified about a friend eating spray oil on toast because she couldn't imagine eating the stuff. And that's one example. So why is this module focused on othered bodies, and why does it matter in graphic medicine? It's important as healthcare professionals that we be reflective and address our own biases on the regular. It will allow us to better connect with our patients and provide better care. So how does graphic medicine play into this? In recent years, there has been a growing push for diverse body representation in comics. Artists and writers have sought to represent a broader range of body types, races, genders, and abilities, reflecting a more realistic and inclusive portrayal of society. Historically, comics are often depicted with idealized and exaggerated body forms, particularly in superhero comics. This exaggerated physique of heroes and heroines were often unattainable in reality, emphasizing physical perfection. Graphic medicine works also challenge stereotypes and biases head-on. They definitely and oftentimes break away from traditional portrayals. By featuring othered bodies, creators have the opportunity to subvert norms, providing a more accurate and nuanced depiction of diverse human experience. Comics have also been instrumental in challenging stigmas associated with certain conditions, disabilities, or identities. By portraying characters with othered bodies positively and authentically, creators contribute to breaking down societal prejudices. There is also something to be said about empowerment and visibility. Othered bodies in comics contribute to the empowerment of underrepresented groups. Characters with diverse backgrounds and experiences can serve as relatable and empowering figures for readers who may not see themselves often reflected in mainstream media. Many characters also embody intersectionality, representing individuals who navigate multiple aspects of marginalized identity simultaneously. This intersectionality adds complexity to characters and highlights the interconnected nature of various forms of social identity. The inclusion of othered bodies also allows comics to serve as a medium for social commentary. Through storylines and character arcs, creators can address issues related to discrimination, inequality, and societal expectations. Othered bodies also provide unique storytelling opportunities. Creators can explore narratives that delve into the experiences, challenges, and triumphs of characters with diverse identities, fostering empathy and understanding among readers. Further, the storytelling can also fall into the hands of you as a healthcare professional. In reflecting on your own biases in comic form, you may find that you're able to better connect and better provide treatment to the patients that you're engaging with in your practice. I want you to think about the experience you pinpointed in Module 1. Develop a short narrative around that, no more than 100 to 200 words. Identify the whos, whats, wheres, whens, and hows, in addition to the overarching message you want to provide to your reader. Think about how the experience might relate to someone else, why it's impacted you, and in what way. Think about the players in the scene. Was it you and a patient? Is it just you reflecting? This is all important for Module 3's exercise. This is the end of Module 2. I will see you soon.